Yeah.
Only one thing I want to add on. We don't, not only we conduct in a serious manner, we also we want to give the feedback. The teacher role is there. So you have to evaluate and tell them where they have written less for a short essay, where they have written more for a long note or whatever. And we have to give them a feedback. If a candidate has done a better paper, ask them to go through a candidate who has done a better paper, wherein he has highlighted the points, he has given the draft. I mean, that way you give the feedback to the students. Otherwise, they keep on doing the same
head of the
mistakes.
department should take the feedback himself, and it should be kept very secret. Otherwise, in the department, there would be so much of disharmony.
No, my purpose of raising that point was not really to question why it is in the program, actually. I rather was benefited in making preparation for this. I wished I would have got this opportunity when I was writing my MS exam. Thank you, Meenakshi.
Yeah, I invite Dr. ROHIT SAXENA, member AIOC North Zone, to present his talk on Thesis Made Easy. He is working in RP Center. ROHIT, all yours.
Thank you very much for the opportunity, and my topic is something which I have also questioned myself frequently. Why have a thesis at all? And this happens especially when I see my residents who are doing thesis under me duck into corridors and hide behind, or as if they are particularly busy examining the card of a patient.
We'll have a group photograph after his talk. Please stay for the
Oh, good. That makes sure people stay, no? So, like I said, these are questions which I have asked frequently myself, and I personally feel that while it's a grueling experience, probably more for the thesis guide than the candidate nowadays, but of course it's mandatory for a PG course, so there's nothing we can do about it, and we can't wish it away even if we want to. The second important thing is that actually all our medical science is based on research. So clinical practice is just an amalgamation of the various research that has been carried out, and in the young, if we do not inculcate this habit of understanding, analyzing, and trying to use that information for daily use, we are actually slowing down the person's acumen and understanding of being a better clinician. It's like if Newton had not understood the significance of the apple falling on his tree, we all will be floating in space because there would have been no gravity. So it's important to identify, to make them realize the importance of little things that happen to a patient, which can become case reports, which can become overall ideas for research. And then, of course, this is the first window for research, and medical sciences offers unlimited avenues for research. So it becomes obviously that much more important for us to open this window, to let them realize the importance of research in daily clinical practice. I'll try and quickly run through what are the important aspects, but with try and examples. Like the most important thing, the biggest hurdle residents feel the idea of what to do. I mean, some of us are in niche areas of specialty like squint or cornea or glaucoma. So it's kind of obvious that the resident is going to do something which I'm going to like or I'm going to propose. But in the end, it's more important that the resident or the student comes out with an idea of his own, what he or she may like. One of my residents wanted to do neurology. He couldn't do it. He landed up in ophthalmology. So he did a thesis on Alzheimer's disease. His bulk of patients were Alzheimer's, and it's a classic piece of study which we hopefully will get it published in a very good journal. So his intervention and his thought process behind the study was immense. Again, the research question. So coming out with the idea, it's like, what do I want to answer? So one of the research questions which you can do here is the current audience actually interested in what I'm saying? So that is my research question. We can do a study here, we can do a cross section, we can do a cohort, we can do a interventional trial. But the first question is it interested? And the hypothesis behind that study is this audience is listening to me with rapt attention. So based on that, that's the idea on which a research can be done. So you have an idea, you formulate the question. What is the question I want to answer by 3 years of research? Then, of course, come the elements essential in any research: the patient, the population you're going to see, the representative sample, what is the problem we are actually looking at. If it's an interventional study, what is the intervention we're trying to evaluate? Is there a cause and effect relationship we want to see, is going to be a comparative study or just an observational cohort. And then of course the bottom line, what are the outcome parameters? So what am I going to actually measure and see for tangible change at the end of the study? So these are essential elements which need to be planned out before we actually head into the study. So again, formulating a clear research question is bottom line. I mean, do patients with ARMD smoke? This is a very ambiguous question. We want to know that how we are going to categorize the magnitude of the insult that is happening, that is smoking, and the effect, which is AMD. And then of course in your methodology you're going to devise methods of measuring the change in AMD. So you need to have very clear questions. They cannot be ambiguous. Then of course comes the issue about selecting your study. Often we are, straitjacketed in the way we have to do a study because of parameters related to either patient population or accessibility to research avenues, funds. All these things are important. But in the end, a good research design can only give you a good answer. As saying goes, a poor design cannot be salvaged by any amount of statistics, and statistics can do wonders. So you can have a descriptive study, which is the most common thing which we do in our clinical research. You have a case, you have an interesting case, you try to publish that, you try to collate a few series of interesting cases and try and find out what is common. So you come out with a hypothesis that, I had these kind of cases and this was what was common in them, and that is why I believe that this factor is an important factor causative for this disease. So you generate a hypothesis by these studies. You can have an compared to descriptive, you have analytical studies where again it's essentially observational. You can have a cross-section study and you can do a large questionnaire running through a group of persons or patients or population in the public. You can take a selected sample from there and have a cross-sectional survey. You can have a case cohort. So you have a cohort where you have a particular set of patients who you're following up, which becomes a prospective study, or a case control, which is more or less a retrospective, where you identify cases and you identify controls and you find out what was the factor that generated this problem in these cases. So all these are observational studies which give us a fairly good idea. But finally, in the end, the best and the strongest results come with interventional studies, an RCT or a crossover study. In fact, crossover studies would have even better outcomes or results compared to RCTs, because the patient is compared to himself. So there, that variable of the individual also is gone, or variable response. So there is a lot of study designs. The advantages of course, the right-hand ones are that they give you more robust results. The left ones are easier to do. And especially in cases which are rare, it's obviously much better that you have a small cohort which you follow, so that you are able to come out with better answers rather than wait for a complete RCT to wait for accumulating those patients. So it's important that the study design be designed appropriately. Your title should be specific. It should contain requisite information without an overload of nonsense. Where the study has been done is only relevant if that region is different from the rest of the country, or else if you have it in India, it is relevant for extendable to the Indian population. For particularly for person-centric studies or behavioral studies, it really doesn't matter whether it's done in India or abroad. What matters is how the group which we are studying is different from the rest of the world. If it is significantly different, it becomes an important factor which is to be included in the title. Aims, the most important thing is what is your aim, and essentially primary aim, because everything derives from your primary objective, and secondary objectives may be byproducts of the research that you're doing. Introduction, of course, the introduction is just telling, in the thesis writing, introduction or any paper for that matter, the paragraph in the paper is telling me what is the need of the study. It's laying the groundwork. How the person who's reading the paper is going to be interested to know or try and understand what you're doing. Why am I doing this research is the question answered in introduction. The review is not just accumulating data that has been done. It helps to improve methodology. It helps to prevent us from repeating things which have already been done. So no purpose repeating somebody else's study. It's extremely important, particularly at the time of protocol formulation, that your review should be robust. Again, searching literature, there is a lot of sources available, and now of course online Google tells us far more than whatever at any time we were able to get from anywhere. So again, methodologies tell you how will you do this study. This is the most important part, and this is where it's going to decide whether this is going to be a study that has a chance in ophthalmology, or you're looking for non-indexed journals to quietly slip the publication in. You need to have where the study is being done, the period of the study design, subjects, inclusion exclusion criteria, your sampling and your comparison group. These are all the most important components of the study, and this is the meat of your study that you're going to do. Sample size is now the next most important thing. It's not enough to use a convenient sample anymore. Everybody asks, what was your sample size if you're doing an interventional study? Inadequate size sample, negative results are obvious. You're not tested enough to know whether it's different or not. And a large sample size, it's a wastage of resource, and insignificant results will come positive. You have so many glaucoma studies which say that Xalatan is better than drug B just because they did 600 patients and found 1 millimeter difference. It may be statistically significant, but is it actually clinically so? So that's why you don't use large sample sizes. And the bottom line for sample size is primary outcome variable. Everything else, of course, including the design, are relevant, but primary outcome variable is your most important factor deciding sample size. And ethics, we cannot undermine this in today's world of ethical research, of everything under the microscope scrutiny, of journals asking for your basic data. In fact, good journals want you to put your basic data online, which can be accessible. So we just had this recent publication in PLOS ONE. They wanted our entire basic data to be uploaded, which could be analyzed and could be checked by others for its validity. So no more is it acceptable that you are not, you're fudging data, and of course patient ethical responsibility is ours, which cannot be ignored. Case record form is just a record of relevant data, and statistical analysis, of course, you must always try and seek help of a biostatistician who is able to help you to understand the various, in fact, things come out which you never anticipated. Your primary outcome measure may be insignificant, but your secondary measures may actually come significant if the study is analyzed well, if the data is collected appropriately, honestly, recorded well. Any research comes out with clear guidelines, whether negative, it is immaterial, but a good study does give us another brick in the wall of science, and that's what's important. In results, just say what is important and try and give good text, tables and graphs so that it is obvious to everybody what you're trying to say. And finally, discussion should have a purpose. Do not rewrite your results. Do not you have critical evaluation. Don't be my baby, so it's the best in the world attitude. You should know your weaknesses and future avenues, and you should justify. You can justify any research, because after all, it's research if well done. Common mistakes: repeating introduction and discussions, repeating results, strong claims and weak results, starting with limitations, or not offering any conclusions, or in fact not discussing your limitations. And plagiarism is again now really a major factor on which many good researchers have been debarred. So it's very important, if you are taking ideas from anywhere, you need to acknowledge them well. And finally, like I said, it's important to be ethical, it's important to be true to your research, avoid dishonesty, take care of writing English. We've got a lot of papers where first line comes and says, improve your English. In fact, very nicely coached that it should be rewritten by an English speaking person or whatever, and I often try to write back that I'm from a non-English speaking country, and any support and help in English is highly appreciated. But that's jokes apart. It's very important that your ideas should be neatly written. Many good papers are just rejected because they're just not written well. Thank you very much.
Thank you, Dr. Rohit, and thank you, speakers, and thank you, chairpersons. And finally, I would like to say that certificate.
Rohit,
Okay.
just collect a certificate from Dr. Vaishali.
And
We'll take a group photograph.
yeah, we will take a group photograph, and we are extremely thankful that you have all come in this classical music session, where we are discussing the classic things. And as you see that in classical music, you have just few speakers and one speaker and few audience. So we are very happy that you are here, and we have dealt with in this fashion such an important meeting. And we wish that from now onwards we have more of this information, that the teachers can be benefited from this meeting. Thank you so much.
So we take a group photograph and then go for a break, lunch break, and we will be back at 2:45 to start the next session. So we'll start our session on time. So teachers, please have your lunch and come fast. So we start at 2:45. Dr. Arun, Dr. Prashant, Dr. Meenakshi, I think I request you all to take the chairs. The chairpersons and the speakers, please take the chairs, and remaining all we can stand behind. It will help the photographer to do the work faster. So we just sit on the chair, and behind this chair, the photographer wants everybody to be behind the chair.
Whoever I'm reading out, if you're here, please come onto stage. Dr. Asim Chakrabarti, Dr. Ruchi Goel, Dr. Somdat Prasad, Dr. Vibhuti Sinha, Dr. B.N. Gupta, Dr. Satyan Deka, Dr. Vijay Raghavan, Dr. Sahasranamam, Dr. Nayana Podar, Dr. Chandana Chakrabarti, and Dr. Arup Bhaumik. The moderator of this session is Dr. Rohit Saxena, who will also be giving the talk, Teaching Surgery in the Operating Room. We are looking for Dr. Santosh Honavar, who has a previous talk before that. But since he's not here, we'll start with Dr. Rohit. Thank you.
Thank you, Dr. Meenakshi. Again, I was the last speaker before lunch, and I welcome you all back from lunch. The moment we can... So, thank you again, and I'll be talking about teaching in the OR. And anyway, it's lucky that Dr. Santosh is held up, because bulk of what I wanted to say teaching is actually anybody enters the OR. In fact, you should have your person well trained in the wet lab before he lands up operating on a patient, on a live patient. So, first, of course, the important thing is, there have been so many tremendous, in fact, just we were talking about how much revolutionary things have happened in the field of ophthalmology. Technology has really overtaken everything that we have, learned till now. Every few years, everything just gets changed. So, transfer of surgical skills from one generation to the next is actually the sheet anchor or the basis of any advancements in surgical skills that can happen. If the resident did not know buckling, he would not be confident enough to go into the vitreous and do VR surgery, and now have such excellent macular surgery techniques available. Now, up till now, the attitude was to have an apprenticeship model where you have an assistant working with you for 3 years, he's observing you, seeing you. And now, because of this massive change in ophthalmology, in teaching and learning techniques, in the actual doing surgery, it's now about time that we change the learning and teaching from do and not just see. So the apprenticeship model should actually now change to something where the person actually gets an adequate hands-on. Now, of course, the Council for Graduate Medical Education talks about comprehensive training. So it not only includes surgeries, but patient care, medical knowledge in general, practice-based learning, communication and interpersonal skills. In fact, for a resident, interpersonal skills, ethics, these are things which are not discussed or talked ever. But I think form a sheet anchor what a junior resident should be aware of. We throw the junior resident at the deep end of the pool. He is, when he joins within 3 months, he's sitting in the OPD independently running, trying to ward off patients who are asking incessant questions. And that's why tempers get lost, because he doesn't know what he's actually doing. So these are important things. Teach about professionalism, how the system works. These are extremely important. And same for any surgery. It's extremely important that before we start doing ophthalmic surgery, we should understand basic life support. We are expected to after our MBBS, but nowadays the way of clearing exams has become so MCQ oriented that I'm still not sure if many do internship in their real way that it was supposed to be done. Again, awareness about anesthesia, how to maintain sterility inside the OT, particularly hand washing techniques, and now in ophthalmology many of these are requiring very special techniques for sterilization. So it's extremely important that any resident be trained for these basic things. We as a surgeon can suffer tremendously if there is a breakdown in the chain of sterility anywhere, whether it's due to us or to our assistant. Before we go for surgery, of course, surgical anatomy, understanding of surgical procedures. Often the resident is unaware of the machine. It's like, giving them a car to drive with just theory about the car, but they don't know how to actually move. So we give them the phaco machine without the basics of the phaco machine being known to them. They should have a demo machine, understanding how things are doing, understanding how the foot pedal works, and of course managing suprachoroidal any emergencies, particularly due to the block which they are most often giving. At RP Center, we have the National Surgical Skill Development Center, where we're giving hands-on training, an animal goat's eye, the surgical stimulator, advanced training modules. We then have surgical videos, a set of surgical videos on which the person or the student is acquainted to. So he's seeing all these videos operated by experts to try and understand what exactly was the procedure that was going on. And they have to have a wet lab logbook for self-evaluation and having a sequence of what all he has done. So this is our National Surgical Skill Development Center. You can see residents operating on them. So before we send them to the operating room, they have to have 15 hours of active wet lab time. And at the end of that, there is a certification provided by the wet lab in charge, which is a dedicated senior resident posted to instruct the new incumbent residents. They are trained firstly on how to handle the microscopes, how to get over the idea of looking at where you're operating. So you're looking straight and you're operating down. This is the first step in learning in ophthalmic surgery. So it's extremely important to be able to get them sequentially working on this. Then there was a thesis done at our institute very recently, in which we found that 2 hours of training on the virtual reality cataract surgery simulator significantly improved capsulorhexis scores. In fact, I'll show you a video of pre and post training for our second year resident, which will show you how different it can be. And of course, in that simulated environment, they practice all the steps of phacoemulsification, achieve basic proficiency in low stress environment, and gain confidence. And this is the most important thing, so that patient safety can be provided. You cannot just let a resident loose onto a patient. After all, it's a human being we are talking about. So this is the simulator that we have. I'll show you the video of, so this was the resident when he started off. This was his rhexis he made. This was the pre-training rhexis. And on this side you can see how he started doing once he went through the 15 hours of 15 surgeries on the simulator. So on the left you can see he's struggling to make it, and on the right and they are in real time. There's no speeding up of this video. So you can see the marked difference in the video of the pre-training and the post-training. It's only after this that we allow them to actually come into the OR. Then the learning aids that are available in the OR. There is a closed circuit LED screen you can see on top that is showing exactly what the surgery is going on. So multiple observers can be trained at the same time. You can link the machine parameters so they can see actually what parameters the procedure or the surgery is going on. Everybody keeps different parameters in phaco. So they need to know what was their vacuum, what was their ultrasound, torsion, what were they using, infusion, flow rates. It's very important for them to be knowing these, because that's the only way they can understand what's going on. Then we have specialized recorders. The Callisto Eye records, which is again shown to the resident, can be discussed with them every step of the surgery. Operating microscopes with the observer arm. So the first assistant is seeing what surgeries are going on. He is seeing the same stereoscopic view as the surgeon. This way they get exposed to not only simple surgeries but also complicated surgeries, and how to manage complications intraoperatively. Intraoperatively, they have a two-way dialogue. Of course, they cannot disturb the surgeon in the middle, but in a complicated procedure, but they have a two-way dialogue. They are able to ask questions and understand every procedure that's going on. And finally, because they are the ones who are going to write the detailed surgical notes, their understanding of the procedure increases. And then, of course, every surgery done by a resident is recorded, and that can be discussed and re-evaluated by an observer, by a resident, by a faculty, so that steps of what went wrong and how it went wrong and what can be done to prevent that can be taken. So this is the most important way of learning, seeing what is happening and then doing what you're seeing, and then have somebody tell you what went wrong and how can you change and correct it. So now technology can actually be very well used to understand these things. Then, of course, is the next step of training on the level which the person can accept enough information. So for a novice surgeon, you're focusing primarily on patient safety, basic proficiency and basic steps in managing basic surgical details. This is the first step for novices. Then you go on to intermediate surgeons who have done a few surgeries. You are improving their efficiencies. You are seeing that they are operating on more complicated cases. You are ensuring that they do not have complications or reducing their complication rate, and how to tackle complications and emergencies. So this is the next step for intermediate surgeons. So the level of case should change. For a novice, you have easier cases where they can manage. For the intermediate surgeons, they are tackling now complicated surgeries. And finally, advanced surgeons who are actually assisting the novices and helping them to tackle complications or preventing complications, because that is the only way you can accomplish, hopefully by not your mistakes but by seeing other people make mistakes, to prevent those mistakes. So an advanced surgeon, like a senior resident in our place, is routinely deputed to make sure that all resident surgeries are completely supervised and are stopped if there is any sign of it going out of control. Then again, they are the ones who are understanding how to manage complicated cases like dislocated lenses or subluxated lenses. So again, under faculty supervision, these senior residents who are now fairly well advanced in their surgical training can manage to do more complicated cases. Again, there is a publication on this, so I thought I'll bring it up. A study said that there is no difference in residents performing under block or under topical, although I would say that I thought it was 15 minutes. 1.5, right. So it's just 10 actually, I was running the watch. So there was no difference between topical versus block, although I would say that there is a lot of difference, and not only from the surgeon, from the patient point of view, because resident surgeries tend to go on for a much longer duration of time, and it is a little difficult to expect a patient to remain fixed immobile for that much longer period of time without moving and without becoming uncomfortable, which can actually compromise long-term results. Then how to instruct? There are three various ways in which surgical training has been devised. The most common, which we actually use frequently, is the forward approach. So we introduce the student in the early steps of surgery, making an incision, if there is a conjunctival incision involved, making a conjunctival incision, entering the cornea, doing a capsulorhexis. This is a forward approach that with every subsequent surgery he is going on to the next and more advanced step. There is a reverse technique which has been described, which is supposed to work better because the bulk of the surgery has already been done. So you start him by the final steps of suturing, which you can supervise and replace. So if the suturing is not done well, you can replace the sutures. You can teach him how to do lens insertion, because although many things can go wrong even during the lens insertion process, but it's essentially more safer than doing the phacoemulsification process at the moment. So you can start the resident getting his understanding on how to handle the eye, how to handle the intraoperative procedure in a reverse procedure. And of course, there will be no significant difference. And of course, the other way is a kind of deconstructed step where you can teach him different steps in different cases. So depending upon the type of the case, the resident gets 1 or 2 steps in the middle so that he again gets confident, and each step he can actually, then there is a mixed technique in which you can actually go back to the wet lab and learn that and practice that technique again. So you learn a particular step and you go back and practice so that that step becomes completely natural for you. So in fact, studies are divided into 7 steps of cataract surgery, which each requires a separate certification and improvement. Then of course, managing complications, the best is that it is under any surgery is under supervision, and you stop and swap. You overcome the chance if the rhexis is going out, you stop, you ensure that the rhexis is brought back. It's now again a round rhexis where the resident can take over again. So you keep stopping in the middle, foresee a complication, prevent it, but get the resident to complete the surgery in the end. That is the single most important thing, because it helps to bring confidence. If he's just heading towards a complication and you stop his surgery, it will be a huge task for him to get his morale back in the next surgery, because he'll always be jittery that this is the place where I made a mistake and I lost the case. So it's extremely important that confidence should be brought by assisting, preventing complications, so that you ensure that the patient does not suffer, but still ensure that the resident is able to complete the surgery on his own. Like I said, there is an integrator, simulator and operating room technique where every step is first taught in the simulator, is practiced on the patient, and that is certified, and he goes back again going from easier steps to more tougher steps. So that is the way in which the surgery process can be deconstructed and taught for every individual step. Again, of course, it's a very time consuming and it's a very person oriented approach. This requires you to know your resident well and ensure that he's able to do each step separately. But like I said, the most common one is the forward one. Then the most important, the post-operative period, is to ensure that all surgeries of residents are recorded. One, you will get to know where he made a mistake so that he can overcome that. Those surgical videos would be the stepping stone for discussion and understanding of complications of residents. So a step-by-step analysis of the video by a senior surgeon, corrections if required in the original technique, and suggest alternatives that could be done at the time when a particular procedure went wrong. And of course, a surgical logbook in the end, which provides all the pre, intra and post-op records, which can be followed up and gives confidence to the resident how he is performing and improving. There are a lot of objective competency-based milestones that can be graded and be marked for residents, which is important when you're maintaining a surgical logbook, and there are many of them which can be followed. But the most important thing is have a proper surgical curriculum with endpoints for each step, with outcome-oriented steps. So you need to know that he has done this process, this is the outcome of this surgical step, and whether he's cleared or not to go on to the next step. So again, like I said from the very beginning, from an apprentice who's seeing and practicing by memory of what went on in the surgery when he was assisting, to an actual competency-based model where the resident actually learns what is happening. There are various surgical curriculums that are there where in different places, which have also certified the minimum number of surgeries every resident should do to gain certain amount of competency. In India, there is a very interesting paper by Krishna Prasad et al. Where they analyzed in South India, and unfortunately, I would say that the statistics that they came out with were very disappointing. So you can see the last line where the median number of surgeries that were performed were so few that we don't really expect that a resident would be competent enough to go out in the world and practice on patients just by doing these few surgeries. So just want to bring forth that there have been huge advances, just like in medical practice, there have been huge advances in surgical training and education. And I don't think we should lag behind in training and teaching our residents the correct appropriate technique so that they can be skilled surgeons. Now, besides cataract, there are artificial eyes being manufactured for all types of surgeries. In fact, in the WSPOS we held in Hyderabad, we taught squint surgeries to residents who were very interested and were amazed at the practice they got of doing squint surgery. So there are surgical hands-on wet labs available, artificial eyes available for every surgery possible. So I think it's time, either individual institutions or as a group in AIOS, we increasingly invest in these surgical educational tools so that there are continuous advancements in surgical process. Thank you.